you bring the uniqueness of both a clinician and a medical scientist background doing research and also caring for patients. Dr. Emily Wood is a psychiatrist, a medical doctor, a PhD, a diplomat of the American Board of Psychiatry and Neurology, board certified in child and adolescent and general adult psychiatry, specializes in working with children and adolescents and adults with autism spectrum disorder, ADHD, PTSD, OCD, anxiety, mood, and psychotic disorders. Emily has unique expertise in treating late diagnosed autistic individuals, including girls and women. She employs pharmacological and medical treatments and works closely with the patient, their family, and their therapist and other team members to develop thoughtful and insightful treatment plans. Loves working collaboratively with and learning from the excellent clinicians at Spectrum Psych LA. Completed the medical scientist training program, the MD PhD at Johns Hopkins University in Baltimore, Maryland. Research in neuroscience. Also completed advanced training and research from the UCLA Center for Autism Research and Treatment, known as CART, the UCLA Neuromodulation and TMS service, as well as so much more. And one of the reasons it's so important to be talking about ADHD and autism on a podcast talking about fibromyalgia and chronic pain syndromes is these overlap. And one of the studies that she was involved in, and you can go to her website, which will have a link in the show notes, was entitled Sensory Overresponsitivity is Related to GABAergic Inhibition in Thalamocortical Circuits. So for all of the non-medical people, that's a lot of medical and anatomical jargon, but it means a lot of overlaps with pain sensitivity. A huge part of my practice is by default, when I care for a lot of people who have these chronic pain syndromes, they also have these differences in how they experience the world. And many of them are autistic and have ADHD. And more could be said, but welcome to the podcast.
Thank you. It's really nice to be here. Yeah.
And I don't know if you can share a bit more about yourself.
Yes. I'm medical director here at Spectrum Psych Los Angeles. We are a clinic that specializes in working with individuals with neurodevelopmental disorders across the lifespan, from as young as 16, 18 months to 75 years old. We can diagnose it and treat it all. And I think because of that, while obviously we hope to be able to help people to detect autism and ADHD when people are younger, because it helps understand them better and get them the resources they need. Because we are able to work with folks across the lifespan, we have become specialized as a niche in working with adults with relatively new diagnoses. So people who are well into adulthood, have jobs and kids, and they're finally learning about their autism or their ADHD. And a lot of them for many years have had diagnoses of chronic pain, of POTS, postural orthostatic tachycardia syndrome. They have had issues with fibromyalgia, Ehlers-Danlos syndrome, and other hypermobility disorders are a big part of what we see. And I think some of the overlapping findings are differences in how the nervous system experiences pain, in addition to all the senses, differences in the valence and what that information coming into the body means for that person. And then also some changes in or differences in the autonomic nervous system. So the fight and flight, the sympathetic nervous system versus the rest and relax, the parasympathetic nervous system. Those are some of the changes we see that are really similar across these groups. And oftentimes there are similarities and then lots of differences. One person with autism is just one person with autism. But it can be helpful to have a sense of the range of different ways that people experience the world. And their pain sensors are definitely one of those.
Yeah. So you talk about your background and the type of practice you have. What got you interested in the world of psychiatry and then toning down to the ADHD autism aspect of things?
That's a good question. So this may give away a little bit about how my brain works. I knew I wanted to work with children and adolescents in psychiatry, but I didn't find autism to be that interesting when I thought it was just a social disorder. The social aspects of it to me were like, meh, what are people that interested? I don't know. So when I learned about the two aspects of an autism diagnosis being the social communication part that doesn't necessarily just depend on language, but the social communication part, but there's another part, what we call the restricted and repetitive behaviors, which is where the need for routine and the sensory differences plays in. That part of it was really interesting to me. And that got me to work with some folks at UCLA, Shula Green in particular, and Marla DiPreto. I was able to bring in my background in neuroimaging research that I had developed during my PhD, and then do some postdoctoral research with them there in understanding the sensory system in individuals with autism and ADHD and trauma. They're not all the same, but there are some overlaps and some important differences in how people with these different sorts of developmental issues experience the world.
So tell us about your training in regard to ADHD, medical school, residency, and now post-residency, the training you had received along the way. The reason I ask, it's important because many people listening out there find it hard to access people, and sometimes they feel frustrated.
Yeah, I wanted to be in school for a very long time, apparently. But I did both an MD and a PhD. In order to do the psychiatry work that I do, I did not have to get a PhD. That was geared, but I thought I was going to be in research for more of my life than I ended up doing. And so I did a PhD in neuroscience that actually focused in neuroinflammation and multiple sclerosis and working in understanding how the brain looks with an MRI machine for those individuals. And so I really focused on my bioengineering background in using the magnetic resonance scanner. And medical school, we do the same training as all other doctors through medical school. And then residency is where we focus on whichever specialty we're going to do. And so I started out in residency doing the first few years in adult psychiatry, really learning about all the range of different disorders, especially for adults, with some dabbling in child and adolescent psychiatry. And then I did a fellowship specializing for a couple years in child and adolescent psychiatry, which is really where my sort of in-depth training in autism and ADHD came into play. And then throughout that residency and fellowship, I was doing some research on the side, and especially then did a postdoc as part of my fellowship in research in childhood developmental disorders. I think it's really interesting that we have limited our psychiatrists to getting that autism and ADHD training in the child and adolescent track, which is really, really a bummer because it turns out that kids grow up. And we now have a lot of adult-only trained psychiatrists who don't feel equipped to manage individuals with autism and ADHD and some of these other disorders that we know start in childhood. It's especially hard for people to wrap their brains around the concept that while we know that when you have autism or ADHD, you've always had those traits. They didn't just come out later in life. As in, we know in someone with schizophrenia, they didn't always experience hallucinations and these came later. Interestingly, schizophrenia might also be pretty developmental in how it comes about, but we know that they weren't having those symptoms. With autism, we know that people were experiencing their sensory world differently and whatnot. With ADHD, we know that people were having some hyperactivity, some inattentiveness, but many people can use their strengths to overcome the things that are challenging for them. In fact, we're all doing that all the time. And the more strengths you have, the further you can get in life with overcoming those challenges. And so while people may have always had those issues, the thing that we do in psychiatry is only a disorder is if it's really causing distress and impairment. And so it's really important to recognize that someone can actually have ADHD that's detected or really only became a disorder to the point that it was causing distress and impairment in adulthood during certain phases of their life. And we're really understanding how different that looks. I think the fact that our country, or maybe even civilization as a whole, is like over the last 20 years has in many areas of not just science, but in many areas of what we do working to understand different intersections of privilege and how we have in so many ways normalized certain groups of people, especially white men in our society. And so it turns out many of the disorders that we have defined have been like what they look like in a certain group of people. Literally, they used to not study women because of their annoying menstrual cycle, because they tried to do studies where there were as few changing factors as possible. And those darn women have this thing that happens every month. And so they literally thought that the way to handle that was to just not study them. 50% of the population right there. And then you look at different IQs, different cultural backgrounds, the way that certain symptoms are going to arise. And once you put in all those factors, you're going to see that actually ADHD looks different in different people. As an example, I think it's really critical for some number of people. The ADHD is picked up in school because school is very structured and you have to be able to behave one way in school. And so the kids who can't behave that way, their symptoms get picked up in school. There's actually a large subset of people who love structure. For their ADHD, school was amazing. They knew where to go at each. The bell rang. They knew what to do. The teacher would tell them how to start the assignment like this, do this. And so their ADHD actually thrived in that environment. And then it's in college, things start getting harder. And it's when they have to go out into the world and come up with their own schedule that they completely fall apart. And some of those other kids who are struggling in school, they do much better in that environment. And so just learning like a simple thing like that can help to recognize that we were missing so many people.
Yeah. And so it sounds just to what you said is that from the psychiatric background, med school, we didn't get a lot of training on this, if any, on this topic. I look back in 1992, my first year of med school, we had Russell Barkley give an optional lunch lecture on ADHD, which you get a fire hose of information. And I'm like, wow, that's neat. That was my first introduction. And then,
And from a non-MD, like someone who wasn't able to even treat it in the way that an MD would be treating it.
but gave us the information. This is, and I had a great preset mentor who said, half of what you learn changes, be humble, continue to be learning every 7 years, half of what you learn changes. So heard that lecture. Okay, that was 92. Isn't that just naughty kids, bad parents, just an excuse? But of course, I'm like, what do I know? I don't know anything about all of these illnesses. And then in my training, I had pediatric residency where I was fortunate in 96 to 2000. That was routine to diagnose kids and treat kids who had ADHD. We were then told to think that autism is rare. It's so rare that you need to send to a specialist. And it was usually the stereotypical type of person we think of in the movie Rain Man. But as a pediatrician and an internist like you, as a double boarded in kids and adults, asthma doesn't go away. We know that actually heart disease is always there. It doesn't manifest maybe until later at age 40 when they have a heart attack, but we know in adolescent and younger kids, we can see plaque development. It just doesn't manifest. So then you get into realizing that in adult psychiatry, many of them haven't had that training. What I don't always get, and I'm sure you can attest to this as well, didn't they all learn that every 7 years, half of what you learn changes? And we didn't know what COVID was, and you have to continue to be up to date and reassess things. But not everybody does keep up to date. And we'll talk more about some of the implications of that. Any other comments on that?
I think people get lazy, sadly. I also think that there are it's like in this particular case with the autism and ADHD thing and where it's taught in our education. It's one thing to say, when you are a psychiatrist and you learn about schizophrenia and then every 7 years, everything you know about schizophrenia is going to change. Part of the problem with this issue is that they're just not teaching it. They're right. They're not even saying it exists in adults. So the concept of half of zero, right? What do I do with that? I think you're exactly right. And also it really involves actually going a full day event instead of just a 1 hour talk at the conference or whatever. I think that is part of what's going on. And then I think there's other aspect, which is that autism, we don't have any medications that treat the core features of autism that we think of, the way we think about it. That doesn't mean we don't have medications that absolutely help with the symptoms a lot. And then in ADHD, we actually have amazing medications that treat the core symptoms. And there is a lot of stigma. And so that sort of combination of like saying this is important to you, even though you didn't learn about it at all, like now you need to learn the whole thing. You're starting from zero. And then throwing in these like disparate ideas about like the treatment for especially as we're getting better in psychiatry, TMS is the future. And there's all these other things that we're working on, but medications are still the bread and butter and they make a lot of sense. And so that I think throws some wrenches in it.
Yeah. And then this kind of the next question is what are the implications? And this makes it hard for people who, especially adults who have ADHD or those who have average to above average IQs who are autistic in childhood and adolescence into adulthood to access a psychiatrist, an internist, a pediatrician, a family practice doctor who diagnoses and treats individuals with ADHD who are autistic. So what are then the implications of having few physicians for treating and diagnosing this group of people?
I think what I see in my practice is a lot of, I think it's little t, but trauma from our medical system, frankly. I think a lot of people feeling incredibly invalidated at every step of their journey through the medical system. It is a lot of just saying, like, when people get to me, they'll be like, but they said it was this and then this. And now you're saying it's really explained by this one thing or something like that. And I have to, pull back and say, I think this is the foundational thing that then all some of these other things, and some of them still apply to you and some of them don't. But what the way as both a neuroscientist and a child and adolescent psychiatrist, I think about it is like the neurodevelopmental disorder came first. And everything else after that is going to interact with that. And so you have people who have just really been through it, really have had to fight tooth and nail to get people to listen to them. I don't know how many times when a person says to me, like, this is the experience I've had when I took SSRIs, what we consider to be the most basic first line treatment for depression and anxiety in psychiatry. A lot of people with neurodevelopmental disorders, autism in particular, have some really opposite reactions that are really uncomfortable. Kids doing really pretty crazy things. And it's not that the medications hurt them. It's not that it wasn't worth a try, because there's lots of people for whom those medications help. But when they tell me that and I just write it down and then nod and they see that I don't like basically push back on it, that couldn't possibly. Are you sure? Because that wasn't in the textbook that I read about how SSRIs work. Is that a real thing? Is that just in your head? Oftentimes right there, people are there, oh, she's listening. She's just writing it down. She's just taking notes. And I will tell him like, oh yeah, I'm not going to promise that we won't address when we think about all the things, like SSRIs are going to be something. But if you told me you have that, I'm going to, yeah, that's real. I've seen it now enough times. I've seen enough parents be like, when they look at you, when you say, have you tried an SSRI? And they just like their look on their face, you can't imagine what I've been through. But you got to pay attention to that. It's not something you can throw away. So I think there's just so many people who feel like they're not understood. And I think doctors really have for some reason taken on like a gatekeeper role of diagnoses, and especially in psychiatry where we have like the DSM, and a large segment of doctors are annoyed when people have come to them with information that they got online. And it's just like, it's not helpful. It's really cool that people come in with information about and can describe their symptoms to you in different language because they watched some videos. That might actually be really useful. That someone said something that really rang true with them, that they can now explain to you a thing that they didn't even know was actually that other people didn't have that. Like I've had people say things to me that were describe a certain thing, put a label on a thing that I was like, oh my God, I have that, right? Like they are coming into my office because our understanding of what it means to be neuroatypical means that we're talking about different things in different ways. So I think there's a lot of people have been really shut down. And so I often the people that come to me are often like, especially as adults, it's like, first we're giving the diagnosis and then we spend 1 to 2 years like working on the depression and burnout associated with going through life that long with having to struggle in the way they were struggling. And from not just the rest of the world, but even from the medical community. And that's really sucks.
Yeah, and you're speaking to the same experiences I have. And one of the mentors, same mentor said, you're going to learn a lot from your patients, which I, as a unexperienced pre-med student, I just listened. I respected him. And of course, exactly what you're saying is when somebody hears something, and like you, I take this in, and there's often a guardedness about even wanting to share some of this, and you just listen and you go through and you don't stop and go, wait a minute, that's not a normal reaction. Wait a minute, no, that couldn't have been that. You probably were just, you said, and there's a lot of examples, but you said they may have come in with X, Y, Z, and whatever before finally coming in and maybe getting an ADHD autism diagnosis. What are some kind of typical common scenarios of diagnoses that may have been given that may not fully have explained some things that are seen often?
Yeah, I think the one that I'm the most concerned about because of the direction it can take people with treatment is bipolar disorder. So there's a lot of individuals who have ADHD, and especially if they've had any trauma experiences, who have what they will describe as emotional roller coasters. When you ask the questions, it's really over the course of hours that they mostly have that, but it's easy for that to get washed out. And what we know in ADHD is that we call that emotional dysregulation, the difficulty staying in that in between place and having the emotion, just having to ride them. But we also will see people with ADHD will describe staying up all night to play a video game. If you actually, I have so many times when I actually press people, they'll be like, of course I went to bed the next day. But if you ask some pretty sort of basic questions like, have you ever gone for a couple days without sleeping very much or without needing very little sleep? And they'll be like, if you ask them, they'll be like, there was this cool video game and I like got totally absorbed in it. And or people with a history of people who have been through traumatic experiences. If I had a 13-year-old girl who had been sexually assaulted and didn't sleep for several days after, she was not bipolar, but she had been through something really awful. And that was part of what triggered some more difficult behaviors from her. But you can see how if you really don't look at the long-term trajectory of the person and be like, wait, what were some of the things, for instance, that brought you into these situations? Oh, that's consistent with ADHD. And then furthermore, to recognize that people with ADHD can develop bipolar disorders. You have to be aware and knowledgeable. But that's the one that is the most concerning for me because it's an extremely different set of treatments. And the bipolar medications really don't treat the core features of ADHD. And so you are putting a wet blanket on something that isn't necessarily going to help in the long term.
And I have patients say to me all the time, Dr. Lenz, you ask questions that nobody's ever asked me before, asked it differently. And when you dive in, oh, you have bipolar 1, and tell me about your manic episode. I have a porn addiction. And sometimes I stay up a couple days in a row and watch a bunch of porn. I'm like, oh, okay. Did you ever think you were on top of the world, grandiosity? Did you actually go out and do a bunch of things? No, or play the video games. Or somebody gets keyed in. It's like that med school. Here's a couple vignette. Here's the reflex answer. This is Lyme disease. Patient in Wisconsin in the summer with a rash, target lesion, boom. A patient who has impulsive, sexually promiscuous, describes racing thoughts, can't sleep at night. Oh, that's bipolar. Yeah. And it's, or they have a hard time.
The 17-year-old with ADHD? Have you met a, yeah.
And that can have a lot of those implications. So that ends up taking a little bit of time, and similar to my experience, it's like just asking, and they're both very important. And just like in the world of fibromyalgia, you can have fibromyalgia, get metastatic breast cancer. You can develop rheumatoid arthritis. You can have something that develops. Both of them are very important to identify, right? You can have chest pain that's atypical, that's related to a perceived stress that isn't caused by a heart attack. And you can also develop a heart attack at higher levels as well. So you have to always be very careful for changing symptoms and ongoing issues. It's important to recognize this. and it's sad that many aren't. And often you're like doing grief counseling, it sounds like, afterwards. Like you talked about in the beginning, as somebody like you and I, as I like to say, it's so awesome when I get a chance to see families. And when you see three generations, when you can now connect with the 9-year-old who's, oh, they're having some of these same things, and they come in, oh, Dr. Lenz, wow, I've been going through this. My daughter's in 14-year-old. I just had a patient this week said, my 15-year-old, I made an appointment for her. I'm pretty sure it's on the spectrum. And when I broached this, because it's so common with these overlapping, have you ever wondered, especially in the youngerish generation, and they're like almost, yeah, I'm pretty sure that does, I wondered, because it's more aware, and you get a 60-year-old, you're like, what's that? Oh, okay, I've been tuned in, but a lot of people are starting to hear more about it. So, talking about some of the basics, because you talked earlier about how stimulants have a very powerful effect on treating ADHD. What makes stimulant medications effective for treating ADHD in children and adults? Talk about how they work.
So, at the most basic level, ADHD is an issue of the frontal lobe of our brain being able to come online flexibly. And this part of our brain is what's good at helping us put aside the things that are happening around us, including some of our emotions that are coming up, to pursue and focus on long-term goals. And the people with ADHD struggle to have the right amount of dopamine and norepinephrine or adrenaline in their frontal lobe to be able to just switch it on and off, to be able to really use it flexibly. The ways that you can turn on the frontal lobe are by doing something that's really interesting to you, and thereby bringing dopamine into some things that are rewarding and bringing that dopamine up. That can help. Things that are exciting, maybe even on that edge of excitement, anxiety, things that sort of get you activated, doing activities that keep you engaged, that'll bring that online. And the other thing that we can do is put in a medication, it turns out, that actually will help you boost those exact chemicals to get the right signal to noise ratio going between the neurons in your frontal lobe so that you have more ability to flexibly use it. The medications that do that, they're called the stimulant medications, even though paradoxically for people with ADHD, they actually help them feel more calm, less hyperactive, less impulsive, more emotionally regulated, and more focused. They are medications that have some of the largest effect size in all of medicine, not just psychiatry, but all of medicine, in terms of treating what we consider the core features of ADHD. They have side effects that for some people make it hard for them to use. And there are certainly some long-term risks associated with, depending on how you use them, and some cardiovascular risks that are the things that all Americans are at risk for and are hard to pick apart because people with ADHD are at higher risk for all the cardiovascular issues. But actually, they're also some of the safest medications in all of medicine, as in we've been using them for 100 years, and we know that you can use them every day for a long time and not have any major problems. No, none of your organs are going to fall apart. So they're pretty amazing medications. And over the last 10 years, an amazing amount of data has, 10 to 20, but especially in the last 10 years, it's just really rolling in, right? About even some of the long-term impacts of these medications. Because we've known for quite a while about how effective they are for treating the core symptoms of ADHD, but now we also know that they decrease all-cause mortality for individuals with ADHD treated with stimulant medications. It's primarily related to accidents. We know that they decrease motor vehicle accidents. They decrease suicide, which for many, suicide, it becomes the most lethal when it's impulsive. But they also decrease, like we talked about, people who have untreated ADHD are at higher risk for a number of chronic medical disorders like diabetes. And when they are able to treat their ADHD, they treat their body better and take their diabetes medications and actually have less complications of diabetes. And then there's things like people being able to keep their jobs, less divorce in individuals with ADHD who treat their ADHD with stimulants. So they're really pretty amazing. And the thing that is difficult about them recently, literally the side effect that I described to my patients that is the worst one now is that they are in a shortage and they're difficult to get, and you will tear your hair out trying to get the medication. That is the number one side effect of these medications currently.
In a sense, not really a side effect. It's a little bit like somebody needing glasses, getting glasses, or somebody needing a hearing aid and they can hear and they experience what it's like to see and hear well, and now they can't access them. And that's a thing we'll talk about in a little bit later. Can you maybe share a little vignette of somebody, maybe a middle-aged or older adult that you might see who gets diagnosed with ADHD and maybe co-occurring autism, and how the treatment with a stimulant might turn or affect their life and some practical, because you've talked about it's good that we have less divorces and less accidents and less impulsive drunk driving and better care, self-care for their chronic health issues like diabetes, and less smoking and less alcohol cirrhosis from self-medicating. But maybe a kind of a just on an individual level, how maybe think of a vignette.
Yeah, I think I can think of a woman who was diagnosed with autism and ADHD in their like late 30s, married, had 2 kids. One of the ways that they had always handled, I think, their ADHD was by being pretty active, like running, being runners, but had really come to use alcohol as the way to treat their anxiety, some depression, and some of the like hyperactivity, fast thoughts that would happen in the evening that made it just hard for them to settle and relax. And so alcohol had really become a thing that was then leading to more depression, because we know alcohol is a depressant, and causing some problems in their family. When they got the autism and ADHD diagnoses, understanding autism helped just like start helping the relationship with wife and family just understand, oh, this is why my brain does this. And it doesn't mean that people should use it as like a excuse for bad behaviors, but sometimes there are real differences in how you see the world, that when you all of a sudden understand, like, oh, I was trying to explain a thing to you that just really didn't make sense to you. Those are critical parts of relationships that can be really helpful. And then treating the ADHD literally within like a couple months, maybe to get on the right dose, he just said, alcohol really makes me feel bad. Stopped using it. Like it for up until then, like it had been like a harm reduction approach from my end, like being like, hey, maybe talk about the things that it like, I hear that you're saying it does this for you, but maybe are there any problems with it? And doing some motivational interviewing to bring some of those things out. And then came in the next month and said, I stopped a couple weeks ago. I haven't had a drink since. Maybe a month later was like, yeah, I had one drink last week. I'm done. And now it's been a year. And things are really, work is going better, is able to get work done at work and not have to bring it home. Things like sometimes people, especially on the autism spectrum who have ADHD, will find that, just as I was explaining earlier with women or people who found school to actually be very containing, some people find that they need a higher dose on the weekend of their ADHD meds than they need on the weekdays, because at least on the weekdays, they like have a plan. They go to work at this time, they do the thing. On the weekend, it could be like when you have little kids, like you could have to go to 3 birthday parties in 1 week. And that's a lot for someone who maybe has some sensory issues with they're a good parent, their kids want to go, all of that. So the medication can help them be more regulated, get through those things without feeling like their whole weekend is ruined, and a lot of improved communication and harmony at home. I think that's a great example of someone, a really high functioning person who can make that switch.
And it's just recognizing there's a different language that somebody speaks that may be not autistic with a spouse and who is, and that, oh, so you say you're yelling at me, but I'd say, no, I'm not. And then they go, but you believe that in a higher, intense, alarming, harsh sound. And then we get an argument about this, and then it actually makes you feel worse, for example. And now that, even though other people don't act that way, and or if they're in a relationship, wow, you're so much drama, it's hard to be around you. And then looking at the whole addiction aspect, this wasn't one of the questions, but as I was working with an adult patient who has a like many therapists who work with addictions, they themselves had an addiction they went through, and then recognizing and screening for ADHD, found out he had ADHD and is doing well. And I said, how many of the people in your groups do you think, as you're listening to them, have ADHD? And he's, wow. And I said, so is ADHD screened for as part of these intake programs? Are they doing a DIVA, adult Connors rating, a developmental thing? Or are they, and you're shaking your head, no.
No. No, yeah. And this is an interesting issue because so many people feel we're overdiagnosing, yada. The thing is that a diagnosis is only as helpful as it gets you treatment and support that you need. So there's no point in saying you have ADHD and you have ADHD. What's helpful is when people are coming to you with distress and impairment, that you actually get them a treatment that will be helpful to them. And if ADHD is the most cohesive way to help them with a pretty large subset of the issues they're dealing with, then that's basically the right diagnosis. I don't know what to tell you. The other thing I think that's really critical is that we have this idea that you either have a disorder or you don't. And ADHD is a really good example of something that really is context-based. There's data showing the ADHD goes away in some set of people from childhood to adulthood. I don't believe that's the case. I don't believe that their symptoms went away. I believe that they found a job and a lifestyle that fit their symptoms. And therefore, the disorder went away because it was no longer causing impairment or distress. That is true. But whether or not they still had some issues with emotional regulation, they're a little more hot-tempered, all those sorts of that, none of that doesn't just go away. We definitely, as we age, we get better at things. We learn to meditate. There's all kinds of things that we can do, but it doesn't go away. And there are certain parts of your life where things you can make things so that they fit you. And there are other times where, like, you are an adult with ADHD. You didn't even know you had it. You have a kid with ADHD because it's one of the most heritable disorders that we have. And you are struggling with this kid who has more sort of obvious symptoms than you had when you were a kid because you didn't get diagnosed. But it's the being able to regulate yourself and help this person get through the things they're working on and their attention issues and their hyperactivity when you actually struggle with those same things. All of a sudden, you are experiencing impairment and distress from your symptoms. And I think that's something we see so much that is hard for people. And there's some of it, oh, I understand my kid because they have the same thing. But some of it is, that's a really hard mix depending on the parent and the kid.
And for you and I who've been working with families and patients for a long time, there may be somebody who has not a lot of challenges in life, meaning they're not married, no kids, they're in college, in law school, med school, and then they add a marriage and kids. And you may say, I'm okay. And I don't want to warn you about you got it or else, but I know what the consequences down the road, and I want you to have a solid marriage. I don't want you to self-medicate, and now you can work out 2 hours a day. And that's a little bit, your wife may not understand when you come home and you need to go for a 2-hour run. And then you throw in on top of this, you might actually, your spouse may have ADHD because you love that fun, spontaneous adventure person in your life. And then, and suddenly, everybody's what change. And so it can have so many impacts on people. And a lot of this podcast, we are talking about these. If I only had to say it once and people would understand this, and it's nice to hear this from experts like yourself. But public perception, some questions about this. There's been a lot of media attention around ADHD and autism with the RFK's mission to find the root cause of autism. What do we understand about autism, and what comments do you have regarding this?
What we know is that autism is multifactorial, that there are a lot of genetics involved in it, a lot of different genes that, interestingly, some really cool studies show that some of the same genes that are associated with IQ are both positively and negatively associated with autism and ADHD. The point being, there is no one cause. That does not exist. It is a difficult disorder for the parents of individuals, especially who are quite impaired, because of the way that it presents generally as someone who is typically developing until they're not. Just as I explained, like with an individual who might not be diagnosed until they're 25, in a way, one could make the argument they were typically developing until they weren't. And it feels like that was done to them. And so when that happens to your young child, that feels like something happened that was done to them. And it's just what we understand to be the case is that their strengths could no longer keep up with the challenges. And so they started displaying the symptoms more at the most basic level. So we know that there are a lot of different factors. There is no way we're going to find a single cause or a single treatment. And because the same genes, for instance, that are associated with autism are associated with higher IQ and some other creativity things and whatever, it's not something that we can even expect to or want to get rid of all those genes from our society, from our population. That's not something that we should aspire to. And so it is without question that we need to continue looking for ways to help individuals with the symptoms of autism, treatments that will help treat core aspects for the parts of the disorder where it's really impairing to be in the world. That's something that we all, whether or not that's your diabetes or your autism, we need to keep looking for treatments. And there should be no goal of trying to erase neurodiversity in our population. It's an amazing part of what makes humans do the things that we've been able to do. And it's a sad state that we're in, that this is where we're trying to put our attention, is as if we could do this one thing, when some of the most prolific studies in terms of data about autism have now been shut down in different universities across the country, long-term data collection and whatnot, because of their funding being cut. So it's a hard time. It's really scary.
And as far as there's a strong genetic aspect, many genes, boy, our brains are complicated, to say the least. And as far as this idea that there's a vaccine cause, what can you say about that?
The original data was a lie. We've debunked it many times now. We know that it's not caused by a vaccine. That's one of those things. I can tell by the way you're asking it. It's almost like to even have to keep answering this question is giving it more weight than it's even worth at this point, which you get. But we know that's not the case. Vaccines save lives. Every single thing that any of us put in our body, including a glass of milk, like we have to think about how it's benefiting us and what the risks are for us. And so vaccines, obviously, they're when you give them to the whole population, you're going to see some adverse effects. And also we cured polio. We did not have measles in this country for decades. They're amazing, and they're not the cause of autism.
Yeah, I think it's pretty clear. It's a little bit puzzling to keep asking a question like that. All right, moving on with these questions. How do you respond to concerns from patients or parents who are wary about stimulants being addictive medications?
A few things. From looking at some of the national data that's come out over the last 10 years about stimulant misuse and abuse, overall stimulant misuse and abuse has been on the decline from the national substance use data that hopefully will continue to be collected, but we'll see. And when I say prescription stimulant misuse and abuse has been overall on the decline, it is any substance that if you take it in ways that are not prescribed can cause good feelings in your body, has the potential to be addictive. What we saw with the opioid epidemic was that, especially when large pharmaceutical companies are pushing their products and telling doctors things that frankly weren't true, and encouraging the proliferation of medications that were highly addictive and can kill people very easily, that can really lead to a major epidemic. And that killed hundreds of thousands of Americans, and that's real and needs to be understood. Prescription stimulants, as opposed to opioids, if you take a few too many, you feel bad, you don't die. If you were to try to get high off of them, you would quickly run out of your medications. And the truth is that there's always going to be some subset of people who will try to use some medications inappropriately. They're literally antipsychotic medications that we're not allowed to prescribe in the jail because some people will try to snort them. Because when you are in bad situations, you will try to use drugs inappropriately. But the truth is that most misuse, when you look at the data of prescription stimulants, is like occasionally using it not as the doctor had prescribed, like taking a few doses extra during finals week for a college student. That is not something that is like a major health risk. And for most people, they do not experience the medications as being something that they even would want to be addicted to, because for people with ADHD, it makes them feel more calm. And one of the most common things that happens for adolescents is that they feel like they're boring. So it's not usually something that they're super excited about taking more and more of. I've worked in the jails. I've worked in the streets of Los Angeles, Skid Row. There are people with stimulant abuse disorders, and that's for street drugs, for meth, for things that are getting them really high. And that's not what you can do with our medications. So in general, I think there's all of that. And that's even before I tell you that treating ADHD with stimulants decreases the incidence of substance use disorders overall. That's the critical component here. So when you treat people's core symptoms of their issues, they have less need of going out and using other substances to self-medicate, and they do better overall. That's how I look at it. I think it's no matter what, I have to be aware that some people can use these medications inappropriately, and that we need to keep an eye on it. Luckily, we have a lot of checks and balances in our system, like ways that we can look to see exactly when patients are picking these medications up. We can talk to them about it. I think a lot of doctors don't like saying to their patients, like, hey, please don't sell this to other people. But that's, if you're worried about a person selling their medication to other people, you need to talk to them about it. So there's lots of these discussions that people are just not interested in having. And we know that if you talk to people about it, help them understand what the risks of giving these medications to other people are, that mainly if you tell them that they won't be able to get their medication, that if they run out too soon or something like that, you talk about diversion, you talk about why it's not healthy, that, the healthy way to use these medications, and you empower people to use their medications flexibly in the way that you prescribe. I think you don't have these problems with misuse. I actually think that last point is really important. I think that you are setting yourself up as a doctor for people to misuse medications if you tell them to use stimulants in a singular way that ends up not making sense for their symptoms. Because then literally when they fill out the form, like when they do these national surveys, they're going to be like, yeah, the doctor told me I should only use one a day. But what I found is I don't always like to take it on the weekend, but there are a couple days a week where if I take one in the morning and one at lunchtime, I can do better in the afternoon. That's what they were doing, was not a bad way to use a stimulant, but it was different from the way you told them to do it. And so now you're setting up misuse. And then you can see how once you've set that up is like they've broken the rules, and you didn't talk to them about the limitations, like how many could you use in a day safely? What would be the pros and cons of that? You might not sleep. That sounds pretty bad. Then you're putting it in their hands. And one of the things that I just like in this similar vein, I have a lot of parents who will do this thing where they'll tell me, and you're going to tell Johnny, about how you can't use these drugs with other drugs, right? And so and then maybe the parent will leave the room and I'll be with Johnny. I'll be like, okay, the truth is that if you take your Adderall in the morning and you drink a beer later that night, there is no interaction that is harmful between these medications. I need you to know that. Because what I see kids doing when I tell them that they can't, when they've been told by other doctors that those medications, that there'll be a problem. They literally don't take their medication so that they can drink a beer later. That's like the worst possible scenario, is for them to not take the medication that helps with their impulse disorder so that they'll be able to drink more later.
Very common in the college graduate, not married yet, going out socializing group, where they go, I don't always take it on the afternoon dose in the evening when I go out and have a little marijuana and have some drinks. And I said, do an experiment. If you take Adderall evening booster dose at 6 o'clock and you go out, I'm pretty sure you're going to drink less, and you'll probably make a fool of yourself a little less, and probably make sometimes a mistake that could get you in a crime, prison, make an assault on somebody for making a bad mistake. You might actually have a nice conversation with somebody and don't feel like you actually have to drink to relax, and you can
Yes,
and drive home and make a good decision and not get in an accident.
exactly. This is what, like, so I have to like deprogram people all the time and be like, truthfully, you can totally smoke weed and take your Focalin. I don't recommend it. Let me tell you all the reasons why that's not great here. And then we have a real conversation about what's actually happening. Weed does this and this, which is actually not good for your frontal lobe to work.
And for some people that I'm coming in, especially with chronic pain syndromes, and it's not legal in Wisconsin, but every state around us, it is, like, we get a urine test and then it may come back positive. Most common is marijuana. And I say, by the way, any Delta 8, any kind of thing, or CBD oil and that, it's going to show up. And they're like, oh gosh, I used it 2 weeks ago. I only used it once. And I'm like, can I still see you? And I'm like, I don't recommend this. It's a little different if I have somebody who comes back and admits they have an alcohol use disorder or drinking too much to self-medicate, occasionally use some marijuana, and then cocaine comes back, and I'm like, oh, so about your drug screen, what happened? Sometimes I'm watching porn and I'm by myself, and it sometimes enhances the experience. I didn't think it would show up on my urine screen. That was just on the weekend. And I'm like, yeah, so let's talk about that. And let's get help. And it doesn't mean you're not going to get help. In fact, one of the fascinating abstracts at the APSARD, and I don't know if you caught this, but it was this huge database, over 1 million people, and they had people who had a substance use disorder and ADHD as a diagnosis. And they looked in the database who was continued to be prescribed stimulants, which only was like 55% of the late adolescents to 65-year-olds. And there was a 16% lower mortality rate in those who were continued on stimulants compared to who weren't. There was a lower rate of Suboxone use. There was a lower rate of being intubated. There was like 5 times more likely they were going to be getting healthcare, whether that, I don't know if it was mental health or going to doctor visits. I took a picture of the abstract. He said it's going to be published in one of the big journals, probably JAMA, later this year. And I said, holy cow, that completely blows out of the water the myth that I've heard from addiction psychiatrists who said, Dr. Lenz, you can't put this person on with an addiction on ADHD meds. And now it's, if you don't, you're putting that risk of killing that person because you're not treating. That's not a small difference. What are your thoughts on that?
I think this is critical. And it's almost like I wish I were surprised by the data you're telling me, but it makes perfect sense from what we know. Like it makes perfect sense to you and I from what we see with our patients and all the other data showing how effective these drugs are. And to be clear, like ASAM came out with their stimulant use disorder treatment guidelines this last year, like the newest ones less than a year ago. And they are very clear that when a person has ADHD and they have a stimulant use disorder, you need to, of course, think about the risks and benefits for them. But if you believe that the benefits of treating their ADHD outweigh sort of the risks, then it's very clear. Every patient is different. But I think any time in medicine you've created a rule that you just don't do X when a person has Y, I mean, generally it's not great. And it's more about you than it is about your patients. And that's a very psychiatric way of looking at it, but it really reflects more on you and your rigidity and your difficulty handling this issue than it does your patients. And so I think that it's very reasonable to have concerns. The person you mentioned, like that person, sending them home with a stimulant to treat their ADHD is just not gonna do it.
So,
It's not that you shouldn't, it's that it's not the treatment for all of the things that they're experiencing. It doesn't mean that in the future you shouldn't treat their ADHD. It doesn't mean you shouldn't consider it even in the pretty near future. It's that there is more going on right now. And so that's the big picture for that person. And when I have exactly like you said, like a kid who, and by a kid, I mean like a 17-year-old who drinks a couple beers with friends every few weekends, has smoked some weed on Fridays with their friend, like some pretty normal adolescent trying out of some drugs. The last thing I want to do is make them think that they can only have one or the other, that they have to lie to me about what medications they're using. And what you said, I think if you take your meds that day, there's a better chance that you're going to choose to maybe even not use. That could be amazing. But I think we set ourselves up for patients feeling like we don't understand them feeling lied to because we are lying to them. And a lot of problems, this is where we look like the sort of, it's the being, looking like we don't understand what our patients are going through and wanting to be paternalistic and have it our way.
yeah, it's trying to look at the context of what's going on, knowing the longitudinal history, and sometimes that's a short-term benefit. Overeating, you can, I jokingly to say, is a man were pulling you over, you were swerving. Were you reaching for some Oreos that fell under the car seat to help relax after a stressful day? We're going to check your Oreo level. We're not going to ask that, but both of them aren't good for your diabetes, and it might cause you to have a heart attack if you're eating a cheeseburger on the way home, and you might have more risks than these other things. What are better options? And just like I say, if somebody has positive, we're going to talk about these things and looking at the picture, and we're going to monitor, regulate you. I have more than one patient who's been a history of heavy substance use, heavy into making choices using their body in the sex trade and other things, and now has been clean, sober, and part of that is comprehensive treatment. Also found out, as you probably can relate to many of these, find out actually I'm autistic and have ADHD. So you get into this other challenges, and now you continue to monitor, it's validating to help with that. A couple of questions on ADHD. Are we overdiagnosing and overprescribing? What's your take on this?
My short answer is no. I think that we are just starting to understand the diversity of our population. And what I explain to a lot of people who have ADHD and some anxiety is that if they can find a cottage in the woods by a creek where all they need to do each day is pick some berries and chop some wood and have the quaint life that we think maybe our very long distant ancestors experienced, instead of driving in a car 70 miles per hour, having a supercomputer beeping in your pocket, telling you to do different things, having to pick up your kids and take them here, and then also do this. And I think a lot of your ADHD symptoms and anxiety would be less if you lived in that cottage. You would also be bored and living in that cottage without your phone. There was also, you would have to leave your family. And it's just, I think we should, as a society, be doing all of the like rest is resistance and recognizing how important it is to do care and slow down, not work as much. And these are important things as a society that we need to keep working on. And if I know my patient is less likely to die in a motor vehicle accident in the next week, year, decade, if they take this medication, then that is obvious. It's a no-brainer. That's how I'm going to help them for right now to make good choices about their life. And we can talk as a society about cottages in our future, but this is what we need to be thinking about, like where we need to meet each other where we're at right now. And I think ADHD medications are a tool to be in our toolbox. Some people need them very consistently. Some people find that they don't need them every day, or they don't need them in every context. And that because they have other strengths that they can use, and saying that we're not necessarily overdiagnosing to say you are someone who fits in this group of people who will benefit from mindfulness training and ADHD meds and some other things that we know are executive function coaching and some things that'll help with these sorts of things. It's not hurting anyone to say, here's another way we can look at what your issues are and what your strengths are.
Yeah. Thanks for sharing that. And you're right. If anything, the implications of not treating and then even mortality rates, quality of life, both for themselves and for other people. How many drunk drivers who've
Right.
killed themselves and other people may have had untreated ADHD and took lives of other people. So it has also not just personal, but also within families and also within society, losses of other people. When we look at stimulants, there's shortages and there's different reasons for that. And it's often very frustrating to find access to this. And there's things that are related to that. And one of them is how they're categorized within the US system as a Schedule II medication alongside with Oxycontin. Can you talk about that? And do you think that's appropriate and why or why not? And how would reclassifying stimulants as a Schedule III medicine affect practice and perception?
Yeah. When the Controlled Substances Act came out around 1970, Nixon had just declared a drug war. And it wasn't until 10 years later that it really got going. But we didn't understand all of the substances that we were dealing with. And literally, like one guy wrote a letter saying, I think that these stimulants are really serious. Rats will press a lever a lot of times to get them. I think they need to be controlled at this Schedule II, like with these opioids. And that's once the law is going, that's where it is. There are stimulant, cocaine and street methamphetamine are extremely addictive, and especially methamphetamine can be really harmful in many ways. But to put them in the same category as opioids, which we now really understand the addictive nature of them, even at the doses that you give therapeutically, like even when you're not misusing your pain medications, if they're prescribed for you to take more than a week or two, you can very quickly become dependent on them. So that's a different thing than medications for ADHD that actually need for most people to be taken chronically to be effective. And in general, people do not need more and more to get the same effect. And at the dose that we prescribe to get the benefits, they're not found to be something that's addictive for them. So I think it is a disservice to have them in that category. It's especially problematic right now in this time and place because the DEA, after the opioid epidemic and the settlements between the states and the distributors, manufacturers, and pharmacies, these cases came together that really gave the DEA a lot more leeway on what they can do in terms of looking for red flags for diversion of controlled substances. And the DEA is a law enforcement agency, and they are not, in fairness to them, it's not their job to differentiate between different controlled substances that are in the same class. They don't understand the differences in how these medications work in the brain and the different ways. Like they're going by the book. So they're literally treating all of these medications exactly the same in terms of their addictiveness and whatnot. And they're telling us that they think stimulants are the next opioid epidemic. So that's troubling. This has led to an issue that because we had one manufacturer go down literally in fall 2022, we had one manufacturer go down, and that started a cascade when the Teva Adderall manufacturing went down of shortages that started and now have continued because it has not been profitable, it would seem, for the manufacturers and the distributors to make more to even meet the quotas that they have been allowed to manufacture and distribute. They're not doing it. And we think that is because in part that the DEA is looking for all the same red flags for those meds, and it's basically too risky. If they are distributing these medications, it puts the pharmacies and each step along the way at risk for being shut down if red flags are found, and becomes this issue of there's all these other medications that people need. We don't want to shut down a whole pharmacy. If you're a pharmacy owner, you don't want to go out of business because you tried to give to people the medications that were reasonably prescribed to them, but for some reason they set off a red flag because they live more than 15 miles from your pharmacy. Those are some of the red flags we're talking about. They're really difficult to understand. So people are just saying, no, we just won't prescribe, we won't do them anymore. We won't give them out anymore. The distributors are cutting off the pharmacies because they don't want to get the red flags pulled. It's a real mess right now. And people are not able to get the medications that they need. People have been on them for a long time. People who have new diagnoses. It's a real struggle. And of course, without question, I can tell you that people in wealthier parts of Los Angeles have an easier time getting their medications than people in socioeconomically disadvantaged parts of Los Angeles. It hurts. It's always going to hurt people who are less privileged more.
And how would reclassifying stimulants as a Schedule III affect practice and perception?
Yeah. There is a little bit of awareness between Schedule 3 and Schedule 4. In this case, the most significant one to know is it's between Schedule 2 and Schedule 3. Schedule 2 medications all have quotas. So the manufacturers are limited in how much they can make. So I think that's one thing. But right now, they're not making even the amount that they're allowed to make. So I think the main thing in dropping it down to Schedule 3 or to Schedule 4 would be that the DEA would not be considering them with the same red flags that they're looking at the opioids with right now. So I think that would be the primary thing, that the quota is the one that makes sense based on what is written in the law. That is the difference between Schedule 2 and some of these other ones. But given that we're not making the amount that is even allowed in the quotas, there's these other factors playing in. And I think it would be those issues with how the enforcers are viewing these medications.
That's a solemn part of the discussion here because we hear the benefits. You said earlier you can take a handful of your OxyContin and be dead, a handful of your Adderall and you're feeling really jittery and like you drank way too much coffee and you can't sleep and you are heart racing and tachycardia and all of that, but you're not dead, and that it's categorized in that same way. That also can lead to, I guess, less doctors wanting to put their toes into that.
Yeah.
Personally, as a doctor who finished med school in the year 2000, 1999, OxyContin gets marketed, and a couple years into this, I had a patient who was a narcotics detective who had the worst luck and kept falling and hurting his back, and he ramped up to some OxyContin, and there were a couple, 3, 4 red flags. And I said, 2002, I said, I need to sign a pain contract. And he's like, what, you don't trust me? And I said, okay, 4th red flag. And this was before we had PDMPs and all this. And I said, I'm never writing this again. This is addicting. So ahead of that curve, I recognize, wait a minute, this is not yet. I'm also ahead of the curve, recognizing, wait, stimulants are actually protective. This is common sense. This is unfortunately even sad to be even thought that way. But what does that do then to the number of doctors who are actually treating kids and adults with ADHD with stimulant medication?
It shrinks them. And then doctors, even psychiatrists, will shy away from using these medications because they feel that there are these greater risks when, as you're pointing out, the risks of death are greater if you don't prescribe them. So it's like most doctors will respond to those sort of threats of this could hurt your license or your ability to prescribe, even when it's unclear what those threats really mean. I mean, in terms of what is the doctor liable for when you are checking the PDMP, documenting and talking to your patient about diversion and the appropriate way to use these meds and all of that, and not prescribing more than these sort of basic things. Doctors still seem to struggle with it and to not want to prescribe them. And I think the flip side is, in addition to talking about how opioids are very dangerous, benzos are Schedule 4 and can kill you much more easily, again, than stimulants, and are really addictive, even, again, in some of the doses that are normally prescribed. I talk to my patients much more seriously about benzo use and the importance of using them for acute situations, and the things that we basically the same talks that we use about opioids and saying, yes, a person in your family just died and you're grieving and you're basically completely, this week is a perfectly fine, please just take this medication, but also we need to taper off next week. That sort of discussion, and to really explain to them that it's addictive and it needs to be used judiciously. But they're Schedule 4. They don't have the same, these are mamas that'll help her, right? Like there's a lot of stigma about stimulant medications, how they might be related to methamphetamine, cocaine, and crack cocaine. And that stigma has racial implications, socioeconomic implications, so many things that aren't fair to the individuals who can benefit from using those medications. And that's part of what's going into these decisions. And when you have legislators in Congress deciding which medications are going to be in which level, and that's difficult because that's not what they were trained to do.
And it's a bipartisan political issue. Democrats and Republicans get ADHD and are autistic, and I think hopefully it'll affect some rational thoughts. This is a bipartisan issue that hopefully rational thought, just like how trying to get support for opioid use disorders and other things, trying to help with that. Yet in many states, there's this push to get Suboxone prescribers. And I've thought, why don't we screen these patients for ADHD and treat their ADHD?
Right.
And really the answer is put more people on opioids, which or opioid-like medication. It's actually screen them. I have an episode of a patient named Jake. I don't know if he'll be on there, but it was an episode about 2 years ago, and he was on Suboxone as a teenager, oxy, and switched in Suboxone. And I was treating his brother for ADHD. His dad died of alcohol use disorder and cirrhosis, was treating his mom, and they were going through this. And I was like, hey, and by the way, he had, what happens when you're on long-term Suboxone? You get low testosterone, which means you have flat affect, you don't have the energy, your libido, all of this stuff. And I was like, dude, you need to treat your ADHD. He was seeing a doctor with doing Suboxone at times. Whoa, what are you, what? You're taking this and you're on this? Wait, where'd that come from? So then the doctor who was doing Suboxone just made him feel bad. I can't continue to give you your Suboxone if you're taking this. And he was so worried about the ramifications of not being enough. So he finally did, a couple years later, came back and started again, and he was able to get off Suboxone. He's, oh my gosh, you were right, Dr. Lenz. Being on Suboxone, really, I didn't have energy. I felt flat. And now I'm better and I can function and I'm doing so much better. And we're getting recognition that, yes, we have an opioid epidemic. What's the best way to treat it? Can we hopefully have somebody who is affected? And I'm hoping there's legislatures enough, then letters written by people on both sides to say, we have to relook at this when we see the data, just like when cigarette companies on the reverse saying, hey, the data is pretty strong. This causes cancer. Hey, the data is pretty strong. This actually makes people die less. They live longer lives. They have less things. Hey, if you're for family values, this will help marriages. If you're for less drunk driving deaths and less car accidents on the road, it's when you look at it, but I know there's so many issues that people have to talk about, and there's a aspect, I don't know, that's my sort of thoughts on all this.
I agree. I think right now, given what's going on at the national level politically, it's really unclear that asking for rational thought is something that anyone is doing. We're literally getting rid of SAMHSA and some of the most important institutions to help us understand and manage mental health and substance use disorders that we have. Yeah, I think that it's a rough time to be doing this work when there's so much uncertainty. And I hope that we can get back on track soon.
As we're wrapping up here, people who listen to this podcast are patients who are living with chronic pain, also with often finding out they have ADHD. I was talking to somebody just the other day and who found me because she heard me on the podcast that I had this, and she saw a couple episodes on ADHD, and I don't think I have this. I'm a 60-year-old woman. I was never hyper. Then we started diving in a little deeper. and going through asking some probing questions, and said, I have a personality just like my dad. He was a hothead and had high temper, and we were type A personalities, and yet may have had a daughter who went on to med school, etc., and having these kind of things and recognizing with that. So there's people who are listening who are living with fibro, and many of whom, probably most of whom, don't even know they have ADHD or are autistic or even know that even concepts exist. Some may, and they're hearing that and they're feeling validated, and they like listening to people like yourself share this perspective and hearing that when I have experts on about this. There's also loved ones who may not have a brain like this, but trying to support and understand. And then there's also clinicians, medical doctors, therapists, psychologists, etc., in this field are hopefully listening and learning. Can you speak to those groups of people as we talk about some of the issues we've talked about and some last thoughts?
Yeah, I think that we are at an amazing time in history where we have an understanding of the brain that we do. We are able to recognize neurodiversity and the special ways that brains can be, the ways that being in our world can be harder for some people than others because of the way their brain is and the way we've constructed our world. We aren't yet there yet with all our technology to be able to help have a person just turn off all the noise when they go into a noisy place. The headphones help, but we are able to understand these things, and we have some medications that really can help people and treatments that can help people to better manage their symptoms and really live the lives that they deserve to be living, which is with less distress and more function to do the things they want to do. So I think that when talking about autism and ADHD and fibromyalgia and POTS and Ehlers-Danlos and some of these issues, we need to recognize that the diversity is wonderful and we know a lot. We have a lot of great treatments, and we want to keep also pushing to help people to move the field forward so that people, if you don't want to take medication and you don't like putting a pill in your body, there'll be something else. For right now, recognizing where we're at and what we have, and that sometimes it's a pill that will be the thing that helps you or your family member or your patient, that sometimes you have to look to giving someone a diagnosis when you're not really sure. You feel like maybe you're overdiagnosing, but they seem to really fit this, that this seems like it really benefits them. And then you put them on a stimulant and they blossom. These sorts of having an open mind and recognizing that we know a lot and there's a lot we don't know, and trusting your patients and recognizing as a patient that, you need to be able to trust in your doctors. And from the point of view of a doctor, it blows my mind that so many doctors think that they must be so great that people want to just come talk to them to get drugs from them. But my experience is that when I go to a doctor, it's because I really need their help, because I hate going to the doctor. Recognizing that people who are coming to you are asking for help and they deserve to get the best that you can give them. I think that's really critical.
And I think it's also one of the most rewarding things when people have gone through so much, as you shared in the beginning and the first part of the interview, that nearly have given up hope. One of the things you mentioned, suicide earlier, when you go, what's the big deal? When I learned that about 2 out of 3 autistic adults have had suicidal thoughts, and 1 in 3 have had a plan or attempt, 40% of adults who attempt suicide are autistic. Even though we don't have a medication, I do think, as I talk about with fibromyalgia, it's often like being blindfolded, bound, and tortured by an unknown assailant without any recourse for relief. And there's so much importance of taking off the blindfold and start seeing this and understanding and okay. And often there's this validation that goes on. And as you listen and go, yep, people have this. And now I've learned many people who often have strong reactions to medications, and you look at their allergy list and it's more than 10. It's in the double digits. You're like, that's actually a marker that they actually may be autistic. They have a neuroimmune hyper response. And that is, we have to start making us think about things.
No, let's see the patterns. Yeah. Is it a diagnostic criteria? No. Do you give them the diagnosis of autism because of their list of, no, but do you think where do I keep seeing this?
Let's ask him questions. Yeah, and you start to add a little bit farther. Dr. Emily Wood, it's such a pleasure to have you. We could talk for more than an hour. I got a chance to briefly connect with you at the APSARD conference, which is American Professional Society of ADHD and Related Disorders. It's going to be held in January for clinicians primarily that are interested in learning. It's great if you are wanting to learn and you've not gotten access. It's a great
Really
resource. And for many people are listening, they might be, I'd really love to connect with Dr. Emily Wood and her clinic there. Can you talk about who can see you? We have people from over 126 countries in the world. I'm guessing you're only seeing people in the US and possibly only people within California and possibly within the LA area. Although I did see that, is there a San Francisco office or?
There's something going on there. Yeah, I'm licensed in California at the moment, nowhere else. And I will see people in California, depending on how the laws go forward for being able to prescribe controlled substances. I think we'll see what happens. But for now, I can see people virtually. I think it's preferable for me to meet people in person the first time, or at least the second I ask that everyone come to see me in person. But I also understand that there are extreme circumstances and different situations. So yeah, the patients that I see and the psychologists and who I work with are in California and largely in the Los Angeles area, but we do a lot of virtual mental health work. And yeah, people across the spectrum and across the age. We have 70-year-old patients who we've diagnosed. We have little ones. We work with everyone. And our psychologists do full neuropsych assessments for autism and ADHD. At this point, we are a private pay clinic. It's rough in terms of, that's how it goes. But hopefully insurance will get better as we move forward. We'll be able to take more.
Yeah, and that's a rough part, trying to meet the needs. And I'm sure you're extremely busy, and a lot of people wish they could. And you run a clinic that has a team approach, right?
Yes.
You have a great support staff, which is really important. In the southeastern Wisconsin area, I had some therapists who we've had overlapping patients who then they go, what? Your doctor actually diagnosed your ADHD and your autism? And who is this? And then when they find about me, they go, I think you need to see a doctor. So then I end up having a large practice. So Dr. Emily, again, thank you so much for being on the podcast and spending your time with us.
Thanks so much. It's been great.